Good morning. Welcome to the first inaugural research webinar of the Award Network for Advancing Workforce Analysis and Research for Dementia. And good afternoon for those of you on the East Coast in that time zone. We are really excited today to have David Grabowski as our inaugural speaker, and we have Charlene Harrington to provide comments. David Grabowski is a professor of healthcare policy at Harvard Medical School. I have known David for a very long time. We were just reminiscing about when we probably first met, which was a long time ago. He has been doing research on long-term care issues for decades now, with a focus on the economics of aging and a particular interest in the areas of long-term care and post-acute care. He did a lot of work over the pandemic around nursing home quality and has been more recently publishing some really important papers around nursing home staffing issues in the pandemic. So we're excited to have him talking today, and then we will introduce Charlene Harrington in a little more depth after he is done. She'll provide some comments. There will be plenty of time for questions and answers. There is a Q&A box at the bottom of the Zoom where you can then provide any questions that you have, and my colleague Laura Wagner will be moderating Q&A when we get to that point. This webinar is being recorded and will be shared on our website when we have the website set up. We're in process on that, and that'll be made available to everybody after this event. So thank you very much for everybody for being here, and thank you, David, for making the time to be here with us today.
Great. Thank you so much, Joanne, for that nice introduction and this opportunity to give the inaugural Award Research Network lecture. What a nice honor. In fact, when this was publicized on Twitter, I had somebody congratulate me with your name, the Award Network. They thought I was winning an award today, but I feel like this opportunity to talk about nurse staff is a real treat. So thanks again for this opportunity. So we know that the nursing home workforce has been a sector in crisis for a long time, and the pandemic has heightened that. And as Joanne mentioned, our team has been doing a lot of research on thinking about what's happened to staffing during the pandemic and how we can support staff going forward. So these weren't new problems, but they were most certainly exacerbated during the pandemic. And I do think kind of one of the real positives is that even though staff have never been more challenged in nursing homes, there's never been a better time to study this workforce. And some of that relates to just the amazing innovations that have happened with the data sets that we now have available to us. So as kind of an overview of what I'd like to do today, I'd like to start by and I know this won't take a lot of work, but just take a couple of slides to discuss the importance of nursing home staff. Nursing home care is as good as the staff working there, and that'll be kind of my first point. I then want to talk about some of the innovations that we've seen with staff data and talk about a couple of our recent studies highlighting these new data. Then kind of pivot and talk a little bit about the pandemic and some of the challenges that nursing home staff have experienced over the last 2+ years. And then finally, talk about how we might begin to fix this. And so I'm looking forward to both offering those ideas and also hearing Charlene's and any others that the group might have today. Let me start by just giving you a broad overview. And as the title suggests, staffing really is nursing home care. We know the building size and the structure of the capital matters. We know there's innovations like telemedicine, but at the end of the day, it's the staff doing the direct caregiving that really matter most for the residents. And there's three main types of staff working in direct resident care. First are the RNs. They're often in a more supervisory role in a nursing home, working underneath them, and nursing home care is very hierarchical in many U.S. nursing homes. You have LPNs, and then doing the bulk of the direct care to residents and patients are those certified nurse aides or CNAs. So labor represents about 2/3 of nursing home spending. So this is the big ticket item for nursing homes in producing high quality care. Let me say a few more words. I think most of the audience probably has a pretty good sense of RNs and LPNs, but I just wanted to spend a little bit more time speaking about certified nurse aides because they're such an essential part of the nursing home care workforce. They provide, as suggested in that first bullet, about 80 to 90% of direct care to patients and residents. They're predominantly female. Many of them are recent immigrants to the U.S. and persons of color. They're paid at or near minimum wage in most nursing homes. And just as another indicator that we don't tend to value this workforce, less than half of them have any health insurance coverage through their employer. They obviously lack other benefits like paid leave, for example. So I think it's safe to say historically, and then we've seen this during the pandemic, we've often failed to really value the individuals doing the vast majority of the caregiving in nursing homes. Lots of research, and I was going to provide sites here, but if you're interested, you could just look at Charlene's CV. She's made a career of studying these issues, lots of good lit reviews on this as well. But the better the staffing models, that means the better train the staff, more of them, the more consistent their tenure, less turnover. All of these have been shown to produce better quality in terms of fewer survey deficiencies, fewer pressure ulcers, less use of restraints, less use of inappropriate antipsychotics, fewer trips down the street to the emergency department or the hospital, and then lots of evidence of greater resident satisfaction and quality of life. Once again, this is a strong literature with lots of different research strategies showing that the better staffing models tend to result in a better quality of care. So then pivoting a little bit towards the second topic here, a lot of the research historically was based on a data set that, although valid, was very limited in a lot of ways. And that, I worked a lot with those data, Charlene did. That was just what we had access to for many years. And fortunately, we've seen a real innovation of late in that we now have much better data. So historically, we had what was called either the Oscar or the Casper. These are part of the survey and certification data collection that occurs when a nursing home undergoes its annual CMS survey. So as part of that, the facility would report based on a 2-week look back period at the time of survey. How many full-time RNs did you have? How many part-time? How many contract? And you would go through all the different staff types, and you as a facility would report this. So it's limited in a lot of ways. One, it's facility reported. Two, it's based on this 2-week look-back period, so it's a very limited time frame right around a survey. And then three, it's just levels of staffing. It doesn't tell us anything about variability over time, turnover. It's a static measure of what was average staffing over that 2-week period. So it's obviously better than nothing, but it was quite limited. And so the innovation that occurred in July of 2016 is that the payroll-based journal, or PBJ data, and I know it's around lunchtime here on the East Coast, and PBJ is kind of one of the more interesting acronyms, but these data have been a game changer. So now every facility submits payroll data. So these are all paid staff, and these are down to the employee level. So you can see an RN working in a particular facility on a particular day. And so obviously these data at the person level allow us to look at turnover, and at the facility level, allow us to look at variability over time. And the good news about the facility level data is they were initially made available on the CMS website. And I've included the URL right there on the bottom of the slide. And these are publicly available. They can be downloaded right off the website. But they basically, let's start with the facility level data, because there's even been some innovations in the PBJ data. But I want to start with the facility level data and a paper that we published a few years ago in 2019. We were interested in kind of I guess publicizing this new data source and checking its kind of accuracy and validity versus the Casper data. And so once again, the PBJ data provides us with daily variation. So we're not stuck with that 2-week look back period anymore. We think it's going to be more accurate because it's easier to audit. It's tied to who's actually being paid. And it's not just on that 2-week, it's the entire year. So 4 times a year, facilities submit payroll data to CMS. And so this was a paper led by a PhD student, Fong-Li Gong, here at Harvard, and my colleague at Vanderbilt, David Stevenson, was a part of this as well. And I just want to take you through our findings at a high level. The first, and these are data back from April of 2017 through March of 2018. And this is just the share of facilities that met a Strive. Strive is a sort of a time and motion study that was done a long time ago, and CMS set up these thresholds based on the Strive estimates and the case mix in your facility. Here's what we would expect you to have on a given day. These weren't regulated levels. These are just kind of statistically, this is what we would expect you to have based on your case mix. And so we calculated as part of that, what share of the time were you at the expected CMS level based on these Strive estimates. And Charlene and I have talked many times about these data. The Strive estimates are actually pretty low, so they probably this is probably an underestimate of what facilities should have in the building. But you can see there, we could calculate on a day-to-day basis how many days were you at the expected level. And you can see the vast majority of the facilities were not at the expected level most of the time. And so this is really kind of disconcerting and disheartening that on average, half the time, the facilities were only meeting the expected level between 0 and 20% of the time. So once again, really, really quite disheartening here. In addition to kind of looking at variability relative to an expected level, you can do very kind of interesting things with these data that you could never do with the Casper data. For example, we were able to show just by day of the week that nursing homes were staffed much lower on Saturday and Sunday relative to weekdays. We know the needs of nursing home residents don't go down on the weekends. There's no reason that we shouldn't have sufficient staffing, yet as a New York Times piece at that time suggested, nursing homes are ghost towns on the weekend. There's just no staff there, and we were able to show that with these PBJ data. We also did a comparison in the paper, both for overall facilities here at the bottom of the slide, and then for the 3 ownership types: for-profit, government, and nonprofit. We just compared what's the total direct care staff in the payroll-based journal data, the PBJ, and the Casper. And for all types of facilities, although it's larger for-profits on a relative basis, you can see that PBJ suggests lower staffing relative to what the facilities were reporting in Casper. Some of that is probably that they were inflating the values in Casper, and that's true across the board. But some of that, and once again, we were able to show in our paper, some of that is just that 2-week look back period. So one of the things we calculated was just what's happening in nursing homes around the Casper survey in terms of PBJ staffing. And not surprisingly, facilities were staffing up around their surveys. And so if you're just counting that 2-week look back period, you're actually getting a very inflated view of what typical staffing looks like in that nursing home. somebody always asks me when they see this, how do facilities know to kind of staff up in the kind of the survey week and the week before? I can't tell you the number of nursing homes I've been in over the years where they tell me, we're in our survey window, we know it's coming, we're on our best behavior right now. And I think that you can see the kind of slight increase going back even 4 weeks before. Nursing homes are kind of anticipating that something's coming. They came in January of last year. They're probably coming back in the second week of January again. We're going to be on our best behavior here. So a lot that can be done with these PBJ data. Of course, that's not all that can be done with them. And so we all know that more than just the level or the variability of day-to-day staffing, those are both really important. We want to know, the average number of staff. We want to know if your staff if your nursing home is fluctuating in terms of their level of staff a lot. We also want to know about how long the staff have been there and whether the staff are turning over a lot. And there was a lot of great research over the past 2 decades suggesting turnover matters. The work of Nick Castle using some of his survey data. There's been some state level data on this issue. But you obviously can't study turnover with the facility level PBJ data that was being released, even though the data are at the employee level. But CMS was not making those employee level PBJ data public. So a PhD student here, Ashvin Gandhi, who's now at UCLA on faculty there, decided to FOIA the employee level data. When CMS wouldn't make those data available, he got a lawyer involved. 2 federal lawsuits later, they released the employee level PBJ data to Ashvin. And so we were able for the first time to really, we think, use these data to their fullest kind of capability. We were able to, in a 2021 Health Affairs paper, look at turnover. And I just want to take you through once again some of the high level findings from that study, just showing you what turnover looked like. And anytime you put up a turnover estimate, it's important to know what you're sort of looking at. We came up with a turnover measure that weighted kind of the amount of time that this particular staff member was working. So if you had a full-time staff member that turned over and she left the facility, that's a big deal versus losing, a part-time worker. That would be weighted a lot less. And so our estimates are large, but I think reflect exactly what was happening here in facilities during 2017 and 2018. And by the way, I think turnovers only increased during the pandemic. But you can see, and these results received a lot of media attention because I think they're quite staggering. The average annual staff turnover rate is greater than 100% for nurse staff. You can see the means above the median, which suggests we're going to see some skewness, and I'll show you that in the next slide. But large turnover, whether it's for RNs, LPNs, or CNAs. So as promised, some skewness here. You can see that there's a lot of facilities that have turnover rates above 100% for CNAs, LPNs, and RNs, even some facilities above 200 and 300%. So once again, these are really eye-opening, and I think got the attention of a lot of folks at both CMS and outside of CMS. And I'll talk about the CMS response in just a couple of slides. So not surprisingly, staff turnover rates vary quite a bit by state. The darker the shade, the higher the average turnover rate. So you can see a state like Texas there having a particularly high rate, whereas Minnesota is quite a bit lower. So some real variability from state to state in terms of their annual staff turnover rate. And then finally, we were just kind of interested, could this measure add value to Nursing Home Compare? And so we just, as an initial check, wanted to see if staff turnover rates were correlated with the overall 5-star rating that's published on Nursing Home Compare at the time. And sure enough, 1-star facilities had the highest rates, and then it's the step function with 5-star facilities having the lowest annual staff turnover rates. So we sort of argued based on this, and I do think staff turnover rates aren't duplicative. I do think they're additive in terms of information, but I do think it's encouraging that overall there's a signal with staff turnover rates and the 5-star ratings. So what was CMS's response to these two papers? The first piece of good news is that CMS in July of 2022 opted to add variables to the Nursing Home Compare website. So they added both a measure of weekend staffing, and I think that's really important. We want to know if your facility is a ghost town on the weekends. That may not be when a lot of us go to look at a nursing home for a loved one. And so if you're there on a Tuesday or a Wednesday, it may look very different than Saturday or Sunday. And then they also added staff turnover. They didn't take our staff turnover measure. They used a slightly different measure, but this was, I think, a real step forward in terms of adding a measure of staff turnover. The other good piece of news is that you don't need a lawyer. You don't need to bring a federal lawsuit to get the employee level data anymore. They've started making them available on the CMS website. And I've got the URL there on the bottom, but starting in second quarter of 2020, the employee level data are being released on the website. So I really, once again, want to tip my hat to Ashwin Gandhi on this. I think he's joining today, but what a great step forward to both have these data now on the Nursing Home Compare website, but also available for research purposes by our entire field. So shifting gears then, we know that COVID has been particularly hard on nursing home residents, but it's also made it very challenging to work at nursing homes. And I wanted to highlight an additional data source that's become available during the pandemic, and that's the National Healthcare Safety Network, or what we call NESN, COVID long-term care data or nursing home data. These data provide detailed information on not just resident cases and deaths, but also staff cases and staff deaths, and not just resident vaccinations, but also staff vaccinations. And so, for example, we can tell from the website that we've had 1.4 million staff cases and around 2,800 staff deaths. Both of those are huge numbers. And I'll talk more about the mortality figure in just a moment. But I would say with both of these are undercounts. And they're undercounts because the early period of the pandemic, we did not have the NESN up. So NESN was not up till the last week in May of 2020. We also see that about 86% of staff got their primary vaccination, and I'll talk more about that effort in a moment. But less than a fourth of staff are up to date on their vaccination. So we have a lot of work left to do in terms of administering booster doses. I think this is not a controversial statement. I would argue, based on our research and the research of others, that staff have not been consistently supported during the pandemic. We know from work led by my colleague Karen Shen, we had a paper that just looked at what happens during and following a COVID outbreak at a facility. And we know that a lot of staff leave, and so they either leave the building altogether or can't work because they have COVID, and that leads to real shortages, which obviously has impacts for resident care. We know, especially early on in the pandemic, there was a real shortage of PPE at nursing homes. There was really limited access for staff in terms of rapid testing, and the staff mortality numbers are just staggering. And I know it's hard to put, like, we've seen so many big numbers during the pandemic. It's hard to put that 2,800 figure into some sort of, try to relate to that. And so what I'd like to do is put up a piece that we did. This was led by Brian McGarry and Lori Porter, who leads the National Association of Healthcare Assistants, which is the largest organization of CNAs in the country. And prior to the pandemic, commercial fishermen, logging workers were the most dangerous jobs in America. And what we calculated is based on the mortality in 2020, working in a nursing home was more than twice as dangerous as working in these other most dangerous settings. So being a nursing home worker was the most dangerous job in America. We did a piece in the Washington Post trying to call attention to this issue. Not surprisingly, given the fact that staff weren't supported, we're down about 310,000 workers, and these are just based on Bureau of Labor Statistics data. At sort of the low point, we were down about 400,000 workers. Things are actually trending up, so there's some good news. We've seen a recovery of sorts, but a long way to go. I'm not trying to argue here that we're short 300,000 workers in nursing homes. We are short of workers. Occupancy and census are way down as well. The point is that we've lost a lot of workers, and you can see that really precipitous drop in March through May, April of 2020. So many people, and I know Joanne is not the only economist, and Bianca and others that are on the line today, and the first thing we as economists think about is we just need to pay them more, and we can solve this with wages. And my response, this is a really nice JAMA Health Forum paper by Cantor and colleagues. And what they showed, they looked at all the different healthcare sectors. And they on the left there, in terms of employment level, you can see nursing homes in SNFs, which are skilled nursing facilities or nursing homes, are the only one that really didn't make a recovery. They're still way down in terms of employment in gray there. But if you come over to the right in terms of average weekly wages, we've actually seen the greatest relative increase in wages in nursing homes, but the greatest loss in employment. And some people say, well, gosh, maybe we don't need to pay more. We lost workers. No, I think the answer is that we don't really know the counterfactual there. We probably would have lost even more workers. The point is that it's going to take wages, maybe higher wages, plus a lot of other things. And I'll talk about some of those other things that we can do to support this workforce in just a moment. I did want to show you one of our papers we did with the NESN data. We did a study led by my colleague Brian McGarry at Rochester, where we looked at using the NESN data to study state staff vaccine mandates. So everyone will remember the federal government mandated vaccines for all nursing home staff in January of 2022. But many states were out ahead of the federal government with their own mandates. In certain states, like Mississippi, they allowed test opt-out options, which we thought weakened the policies. There were other states, like here in Massachusetts, that didn't allow a test out option. But what we did was we collected data on all of these different vaccine mandates, and wanted to study, one, what was the impact on vaccination rates, and also what was the impact on overall staffing. And we knew that there was a potential of these policies for both intended and unintended consequences. The intended consequences are obviously that we hope vaccine uptake will increase in the context of the mandate. Some vaccinated staff who previously felt unsafe might come back to nursing homes. That would be another intended consequence. An unintended consequence is obviously that unvaccinated staff might leave the workforce, and so we might have this mass exodus of staff due to the mandate. And here's our top line findings from that piece. You can see that the states that didn't allow an opt-out had the strongest kind of effect here, but it was pretty strong in both sets of states. Vaccine rates went up following states implementing these mandates. We also studied whether we saw a big spike in reported staffing shortages in the NESN data. we didn't see that. We didn't see a lot of, a big increase in facilities reporting staffing issues. That could be because facilities didn't want to report staffing shortages. That could have been because they were already in a shortage. So this isn't the perfect measure. We can return to this research question with the payroll-based journal data to get a kind of a better sense of what's happening in these facilities. But as best we could tell, the policy had its intended effect and really didn't have a strong unintended effect in terms of losing staff. So this was one of the, I think the real mandates were one of the real, I think, success stories in nursing home policies, maybe one of the few success stories in terms of nursing homes and COVID. There's ways also, and I just want to give an example of this, of combining the PBJ and the NESN data. This was a piece we did, once again, led by Brian McGarry, that we published in Health Affairs, where we wanted to look at what happens in terms of staffing. How are staffing related to the cumulative number of COVID cases per 100 beds? So we controlled for size of the facility here. We wanted to see per particular kind of size of facility, how many cases, the COVID cases among residents does the facility have? And you can see, and this I think is a really powerful and intuitive result. The strongest staffing measure in terms of COVID cases was staff size. So the more staff you have in and out of the building there on the left, the more COVID cases you have among residents. And obviously you want more direct care hours per resident day. That's important. The share of direct care hours provided by nurses, they're kind of trending in the way we might hope, but it's really amazing how important staff size was. And there's been kind of nice research suggesting small home models had fewer cases as well. So a lot of evidence that kind of more full-time staff, less part-time staff, and contract or agency staff are really important. So final topic, and then I'll turn this over to Charlene. What do we do to fix this? And I published a piece in March of 2021 in Politico, where I argued that we know nursing homes need a lot of work. Here's something we can do in the short term. And if somebody put me in charge of nursing homes, I would start with staff. Because as I said earlier, they're really the backbone of nursing home care. If we're not going to have good quality care without good quality staff. And so the ideas I put forward in that piece, yes, once again, we need to improve pay and benefits, but that's not all. We need to implement minimum staffing standards. In order to pay for that, we need to increase reimbursement rates, and especially Medicaid reimbursement. I think we need to ensure that the dollars we're putting into Medicaid are going to direct care. We don't want to put more dollars in that are going to private equity groups, for example. So we really need to pair higher reimbursement with greater financial transparency. And then beyond kind of payment and minimum staffing standards, we really need to think about career advancement for CNAs. And there's been a lot of work of late on career ladder programs. And then we need to make these better jobs. And I did a big evaluation, for example, of Greenhouse several years before the pandemic. Greenhouse is a better work. There's a lot of great things about the Greenhouse model, but it's a better place to work. It's less hierarchical. Direct caregivers are given more autonomy. So it's not just pay. It's the actual job itself is better. Many of you already know this, but President Biden has put forward a package in February of this year where the administration is looking to reform nursing homes. There's three big pieces to that, but a major piece of it is minimum staffing standards. And so CMS is currently doing a study of what that might look like. So there's real action on this right now. They're also looking at increased quality accountability and better quality and ownership transparency. So some of the regulatory pieces are there. I think the open question is, how do we pay for this? Some of that might be increased accountability in terms of how nursing homes are spending their money. I think the elephant in the room is whether it's going to take more dollars to pay for this. So some final thoughts, and then I'll open it up. Staff are critically important, once again, for delivering high quality care. We knew that before the pandemic. That's only been magnified over the last 2+ years. I would argue our ability to study this workforce has never been better. And we have these incredible innovations with the payroll-based journal data. The NESN data are quite rich as well. So although things are somewhat dire in the workforce, I think we can make the case that staff are incredibly important and what's actually happening on the ground in a way that we never could before. And I'll conclude by saying we need major policy reform. And this is the presentation today. I was able to highlight some of my co-authors along the way, but all of them, this is a team effort. And so I'm grateful for their collaboration. And I also wanted to thank NIA, Robert Wood Johnson Foundation. I got don't tell them I got the acronym wrong there, and the Warren Alpert Foundation for supporting this research. So I'll stop there and turn it back to Joanne and Charlene.
Great, thank you, David. And I see questions are coming into the Q&A. Please, people can put in your questions in the Q&A. But before we turn to that, we wanted to invite Charlene Harrington to provide some comments. Charlene hardly needs any introduction, but I will introduce her anyway. She is Professor Emerita from Sociology and Nursing here at UC San Francisco. She actually was the director of the California Division of Licensing and Certification in 1975 in that period of time, and then joined our faculty at UCSF in 1980. She has served on many national commissions and national organizations advising about nurse staffing issues in the nursing home setting predominantly. And that advising has come from an incredible body of research. So she really is one of those unique people who has both been in the trenches as a regulator, as an advocate, and as somebody who knows her way around a data set. So Charlene, I'm looking forward to your comments on this topic.
Thank you very much, Joanne. I want to thank David for his excellent presentation. I think we owe David and his colleagues a great debt for all of his research, especially the research on the workforce in the last few years that's documented the understaffing, the wide variation in staffing, the high turnover rates, and the importance of showing these problems and how they impact on quality of care. So I think certainly his work has contributed nationally, and it's had a big influence on the CMS Nursing Home Compare 5-star rating system. To improve the workforce measures that are on the website. So we thank you for that, David, and for all your colleagues. I think, what David showed is that there was a perfect storm that was created before the pandemic, and that was with the low staffing, the low wages and benefits, and the high turnover rates, so that nursing homes were not prepared when the COVID pandemic hit. And the situation resulted in many infections and deaths that probably could have been prevented had we had better staffing and better support for the staff. So this huge drop in workers during the pandemic has been a big concern. And of course, nursing homes have been arguing that there's a shortage of workers and they can't hire workers, and this is why we still don't have enough staff today. I think, as David pointed out, that during the pandemic, the occupancy rates dropped substantially from about 81% before the pandemic down as low as 68% of the beds were occupied. And currently it's only 73% of the beds that are occupied. So the occupancy has not come back since the pandemic. And certainly the problems, the infections, the deaths have raised a lot of concerns about people even going into nursing homes. So I think one question is whether the nursing homes actually were the ones who decreased their staffing when the occupancy rates started dropping, because many nursing homes staff to census rather than staffing for the needs of the residents and the acuity of the residents. Or did many of the workers probably did leave because of the poor working conditions and being afraid of getting COVID and so on. So it's and as David pointed out, the low vaccine rates are a big concern, because we still have COVID outbreaks happening all the time. This week I heard about one of the best nursing homes in Berkeley has a big COVID outbreak. And clearly these COVID outbreaks are related to the low vaccination rates of the staff. So we need to do much better in trying to get the staff vaccinated. The wages and benefits continue to be a huge concern, because they're less than what hospital wages and benefits are, and wages are going up among other entry-level jobs. So it does make it harder for nursing homes to compete. But I don't think the wages of the workers has been keeping pace with the other growth in wages and benefits in other areas. So how do we get the nursing homes to, first of all, agree to have adequate staffing, and secondly, to pay their workers and adequately? Let's see. David covered so much territory here that it makes it harder to respond. But the issue is, as David said, is what are we going to do going forward? Certainly having all this new data and having CMS track the workforce data more appropriately means that CMS could start enforcing the staffing requirements, even without using the annual surveys to do the enforcement. They could issue fines and penalties for nursing homes that aren't meeting the federal requirements, and for drops in staffing on the weekends, and for the high turnover rates and so on. There's one other point that I wanted to mention, and that's about the training of the workers, because you not only need adequate staffing levels and adequate wages and benefits, but the workers need to be trained properly so that they feel confident in the work they're doing. And we know that during the pandemic, CMS dropped the training requirements for CNAs. So the estimates are, well, first of all, the training requirements were, in my view, completely inadequate. The federal requirements are only 75 hours for CNA training. But it's estimated as many as 300,000 CNAs are currently working without even having the 75 hours of training. So that's another big concern. So there's much to be said about the trying to improve the situation. And I agree with David's recommendations in terms of the policies we need to work on. And we're very pleased to have the White House's support for this, but we have to see if they're going to be able to follow through and actually implement a lot of these changes. And I definitely agree with David that just increasing the reimbursement to nursing homes is not the answer unless those increases are targeted to improving the number of staff and the wages and benefits. Because we actually have lower staffing levels right now in nursing homes, slightly lower than before the pandemic. So there's much for policy people to consider. And thank you, David, for bringing all these things to our attention. So I'll turn it back over to the question and answers.
Thanks, Charlene. Laura Wagner, my colleague here at UCSF, will be moderating the question and answers. Laura is a professor in the Department of Community Health Systems and is a nurse researcher whose own expertise is around nursing homes in the long-term care space. So take it away, Laura.
Great. Well, we have a number of really interesting questions. So David, here's a question around which positions are most in shortage. You talked a little bit about that. And is there an opportunity, I'm going to broaden this question a little bit to say other industries where there were layoffs, where that could be a potential pipeline for us to think about as we expand the workforce in long-term care?
Yeah, so great questions. All three are, RNs, LPNs, CNAs. All we're seeing shortages across the board there. I think in terms of the pipeline with the CNAs in particular, unfortunately, it ran the other direction during the pandemic. That a lot of these other sectors were recruiting, whether it's going to work for Amazon as a delivery driver or going to Walmart and fast food restaurants. There was just a real effort to recruit folks away. And I think it comes back, as Charlene said, we haven't kept pace with pay, and things got quite dire in nursing homes during the pandemic, and it's always been challenging, but particularly so. And so, unfortunately, we lost a lot of workers. I think getting them back, yes, it starts with pay, but opportunities to kind of build that workforce here in Massachusetts. We're thinking about a career ladder model right now as a state where individuals can start as a CNA, go back, get their LPN degree, and I'm excited by programs like that. It's going to take a lot of strategies, and that's one of them that I think is really important.
And similar to that, have you looked at the data on areas of the United States where there were greater shortages, such as rural facilities? I'm wondering if you didn't speak too much about geography in your talk.
Yeah, I'm so glad you raised that. Everything I said today is basically magnified for rural areas. I mean, we do have issues in urban areas too, but rural, between some of the nursing homes even having to close over the last, even prior to the pandemic, the workforce issue there is challenging, and it's challenging not just for nursing homes, but for home and community-based providers as well, given the distance issues. So I absolutely, geography matters here, and I think most nursing homes are feeling a crunch, but the rural places I'm talking to are seeing it in a much larger way.
Great. Another question that was brought up, you didn't mention medical directors or other professionals, and I'm just wondering if you can comment on, I know that we've done some work with Paul Katz in Florida on this, just the role of medical directors and how can we get more input and buy-in from that profession? Yeah,
this is a huge issue. When a medical director is a strong presence in the nursing home, it's a game changer in terms of the workforce. It's an incredible resource, but there's real variability, with some being incredibly engaged, the Paul Katzes of the world. I want that as the medical director at my facility. Then we have some folks who are working across a number of facilities, and we don't even really know their names. There's been a real push among the Medical Directors Association to actually just get a registry or a list of who is the actual medical director in all these facilities. And once we have that, we can begin to sort of think about, okay, how engaged is this person? Because I do think there's some nice models showing medical directors matter. I've seen this in my own research and talking to folks, but it's been a hard group to study because they're kind of removed. And we have some data, for example, in the PBJ on hours of medical director time in a nursing home, but it's not clear whether it's the right measure to study this population in terms of engagement. So I would love to see more research on that. I think it's important, and I think we saw the importance of a clinical presence during the pandemic, especially. And how do we? I think we need to prove the data first, and also the accountability there. But I think the Medical Directors Association wants that. I think good medical directors want to be recognized, and so I'm hopeful that we'll see some changes there.
Yeah, and with that, the certification make a difference, which is a whole other area.
Something I know, and Charlene may know more about this than I do, but I know California is going down that path of wanting to certify their medical directors, and it's a process. And it's a great question. I don't think there's any research that speaks to that, but anything we can do to kind of formalize this workforce a bit is, I think, a step in the right direction.
Charlene, did you have any comments about the medical director?
Well, I agree. It's a good step forward, and certainly we need to know who the medical directors are, and they probably need a lot more training on some of them anyway, in terms of how to manage the residents.
Great. There was another really great question just posted here around, who this workforce is. You mentioned it in one of your earlier slides that many of the workforce are people of color. There's inequities. It's primarily women, immigrants. And Terry Harkin said, just really looking at acknowledging the role of unions in long-term care. And I know you didn't mention that much, but we've looked at some of that data as well around wages in our research. So I'm wondering if you've got any comments on how we can do more research with, thinking about the unions in mind.
Yeah, we did a study. This predates the pandemic, just looking at what are the differences in union and non-union facilities, and we leveraged kind of that voting threshold at 50%. So you can look at facilities that were just above and just below, and they're quite similar. And the only difference was one just happened to meet the union threshold, and one was below it. And just as you suggested, Laura, better wages, more staff at union facilities. So there seemed to be some real positives. I've long argued that this seems like a sector ripe for increased unionization, yet rates are still pretty low, and they're pretty concentrated. Like New York State has a really strong presence, but other states it looks quite small. So I'm excited that you and others are still working on this issue. And there was even some nice work about unions and vaccinations and case rates, and like even thinking about unions in the context of COVID. And I think the punchline there is better supported staff means a better nursing home. And so I think there's something that was quite compelling about that research.
Charlene, did you have any comments on unions? I know you've talked a lot in your research about unions.
Yes, I think the new research that was out during the COVID showing unionization helped reduce the COVID rates was pretty impressive. So
great. David, there's a few questions on the chat, just data questions that I wanted to ask. A few people have asked. Did your data include VAs? I'm assuming no. Or
yeah, unless they're Medicare certified. So like a state-run, like we have a state-run VA home here, which would not be in our data, wouldn't be in the federal data. But then, and that's become a real issue because some of those facilities had some of the biggest outbreaks during the pandemic, and so But if they're a Medicare certified place, they would have to be in our data.
Definitely. And then another question around the CMS data, is that available only for research or is it publicly available?
No, publicly available means publicly available. So everyone's welcome to do their own research here. There's no
Great. Well, we hope some of the attendees today will look at
download this data.
Definitely. And there's
a spike on the CMS website. I think you should take credit for this if there's a lot of
And you had a slide earlier in your presentation where I believe it was the mean and the median question, and then you had the skewness table after that. One of the attendees asked which staff category had the longest tail of skewness.
Oh yeah, the CNAs tend to have the longest tail, although all three were reaching out to 400%. So it's that's like, I don't know, Charlene, you've been doing this, research that's just mind-boggling to have 400% turnover in a nursing. I mean, that's that there's just no way you can develop strong models of care when your staff are turning over that often. We had stories during the pandemic of staff having to move around, and dementia care, just losing your typical caregiver, having these horrible effects on resident care. You can imagine that's just the normal state of business at these facilities that are cycling through staff. There's no way that they can be trained as Charlene said. I'm so glad that Charlene raised training as such a key issue, but then familiarity with the residents, and just you're basically every 3 months it's a new set of that can't be a high quality model.
I might comment that Dana Mukamil's research showed that the turnover was advantageous to the nursing homes because they can bring workers in at the lowest pay rates, and so that's a key issue that needs to be dealt with.
And that's why it's so important. Oh, sorry to interrupt, but that's why we needed it on Nursing Home Compare. As you know, Charlene and I both used to be on the CMS Nursing Home Technical Expert Panel, and we've been arguing for those data for a long time, Charlene, because they're so powerful, and exactly because nursing homes have let's just churn through workers, whereas the public can't. If the public can't see this, but now that it's public, at least there's some accountability.
I wanted to ask David about the CMS turnover measure, because it's much lower the way they're calculating it. And I'm wondering if that calculation isn't a disservice to the public.
Yeah. So thanks, Charlene. I was a little disappointed. So the good news was that we hope our research and many other people like yourself, Charlene, telling them they need to do this over the years kind of moved the needle. But like a lot of things, it was a small victory in that they did publish a turnover rate. But unfortunately, they didn't take our measure. Our measure, we really spent a lot of time, and it's more technical, but really wanting to weight, what types of staff were turning over, and really accounting for staff turning over multiple times during the year. The CMS measure is much more limited in that it's kind of everybody is treated the same. It doesn't account for, as I understand it, for multiple sort of individuals turning over. So as Charlene said, they get a much lower rate, which doesn't, I do think it's correlated, the good news, with our measure. So I don't think it's wrong per se, but it does kind of deflate overall turnover rates, maybe doesn't give as accurate a picture, especially on those tails. So if I was once again in charge of nursing homes, this would be one of the things I would say. CMS should change this, but I do think their argument is that it's simpler, and they're still getting most of the answer there.
Yeah, and there's actually our colleague Stephen McCall posted a comment about this. Do you have any guidance on defining the denominator, and should researchers use a more inclusive method to quantify the workforce?
Yeah, and I like that question a lot, and I do think, and we talk a lot in our study, I do think kind of including all of the workers that are there, and then kind of weighting them, because if a part-time or a contract, if they're bringing that's not as big an impact as losing that full-time staff member, and then having multiple people come in and out. I do think a broader kind of the way we treated the denominator is the correct approach.
Great, thank you. We're at time. Joanne, do you want to jump back on here and thank our speakers?
Yes, I'm sorry that we didn't have time to get through all of the questions, but what a great discussion. Thank you for everybody for contributing to it, because it was just what we were hoping for. We are putting together our next webinar, which will be in early January, the second week of January. Usually we're the first week of the month, but because of the holidays, we're going to do it the second week. And so keep your eyes open for the announcements about that. If you are not currently on the Award Network mailing list, you can write to me directly and I can make sure that you get the link to sign up. And we will have our website up and running very soon. So when we do, we'll make sure everybody knows about that. Thank you so much, David and Charlene, for taking your time this morning, or this afternoon, in your case, David, to be with us. And thank you to everybody for attending. We really are happy to have some enthusiasm around making policy improvements and really evidence-based policy improvements in this area. And all of you who are participating in this network are hopefully going to be contributing to this kind of work in the future. Thank you, everybody.